Hi, everybody. My name is Mohamad Mohty, and I'm professor of hematology at the Sorbonne University in Paris, in France. And I'd like to welcome you all to this special webinar by the International Academy for Clinical Hematology, IACH. This is a very special webinar dedicated to the hot topic of COVID-19 and the management of hematological malignancies in this very severe crisis that we are facing worldwide. As we all know, unfortunately, this pandemic is creating lots of challenges for our health system, for the many patients who are suffering or who died worldwide, but also when it comes to patients who are suffering or being treated for hematological malignancies, it's creating an additional level of fear, but also raising lots of questions about the practical management of these patients, how to deliver therapy, how to protect these patients during this pandemic. And for the purpose of this webinar, which is going to be in the format of a debate, I'm joined by Professor Christian Chabannon from the Cancer Institute Paoli Calmette in Marseille. He's a top expert in the field of cellular therapy, and we know that the activity of stem cell transplantation, whether autologous, allogenic, but also the use of cellular therapies like DLIs or CAR T cell, is also being challenged during this period. Before we start this discussion, I would like to draw your attention to the fact that this is a very rapidly moving field, and things that are being discussed today may not be relevant tomorrow. We also need to be extremely humble about the claims we make, because we are lacking a lot of evidence-based data, unfortunately, because this is a novel virus and we have only to rely on empirical observation, experience of colleagues, common sense, and things that we know from the management of other serious and severe conditions. So when preparing this debate with Professor Chabannon, we thought that during this crisis, the objectives of treating a hematologist would be obviously to protect the patient against this coronavirus and avoiding them to get this COVID-19 infection because they are highly immunosuppressed. In parallel, I think we all agree that we would like to maintain a state-of-the-art management for these patients, because obviously an acute leukemia cannot wait, refractory lymphoma eligible for a cellular therapy cannot wait, and there are many, many examples. Also, at the same time, and this is very critical, we would like to pay attention to the healthcare professionals, the physicians, the nurses, social workers, all those guys involved in the management of these patients, because obviously healthcare professionals, like the rest of the population, are going to be infected for some groups, but also they can get the infection from the patient, from the work in the hospitals and healthcare facilities. So these are the overall objectives that we thought we need to discuss, and we structured this through a few questions. And my first question to Professor Chabannon is about the risk of COVID-19 infection in the patient we usually treat, those patients with hematologic malignancies like acute leukemia, myeloma, lymphoma, whether they have received a stem cell transplant or not. So Professor Chabannon, what are your thoughts about this topic?
Well, welcome to all, and first of all, I would like to add to this introductory words my wish that all of you stay safe during this crisis. To get back to the question, our patients diagnosed with hematological malignancies are very likely at increased risks to contract infection with the SARS-CoV-2 virus and potentially to develop more severe forms of the disease for a variety of reasons. Many of hematological malignancies are associated with immune deficiency. We do use immune suppressive drugs widely, in particular steroids, and I'll let Professor Mohty specifically comment on the case of multiple myeloma, which may especially be at risk of developing severe forms of the COVID-19 disease. And our colleagues in the UK, who always adopt very pragmatic approaches, recently published a list of vulnerable individuals in the context of the COVID-19 pandemics, and all of our patients treated for hematological malignancies were categorized as vulnerable patients.
Yeah, absolutely. I think we all agree that patients with hematologic malignancies are at higher risk of contracting this COVID-19 infection. And although we do not have specific studies looking specifically into this subgroup of patients, however, we do have studies published by our Chinese colleagues in patients with cancer, showing, for instance, that those patients who are treated for cancer have a hazard ratio between 3 and 5 of getting a more severe outcome if contracting the COVID-19 infection, whether it is about admission to intensive care, whether it is about mechanical ventilation, or even, of course, the worst scenario about death. And this brings me actually to an additional and more specific question to our field, which is about the auto and allogenic stem cell transplant settings. For instance, auto transplant is a key indication for multiple myeloma, and Professor Chabannon has already alluded to the fact that multiple myeloma patients are highly immunosuppressed because of the huge amount of dexamethasone they are receiving during the course of their therapies, whether frontline or during relapse. I'm not aware of any multiple myeloma therapy that does not include dexamethasone. And we know very well that pneumonia is a very common and probably potentially severe complication in multiple myeloma. So Christian, what are your thoughts on how we need to deal with the auto patient and allo patient in terms of infectious risk but also in terms of preparation. And in other words, those patients who are candidate for auto and allo, what is your approach today?
Well, there are at least two avenues to consider. One's that we already discussed, which is the risk to the patient to add autologous or allogeneic transplantation to prior treatments. And the second one are the disruption of the supply chain for autologous and mostly for allogeneic stem cell transplant. So let me start maybe with the second aspect. It is a challenge today to organize autologous, but mostly allogeneic stem cell transplants for our patients. For autologous, that means that the patient has to come on several occasions to the hospital, and many efforts conducted by hospitals are to restrict access to the hospital for patients and for families in order not to favor dissemination of the COVID-19 disease. So as part of a global strategy to treat lymphoid malignancies, one has to consider when and where to plan the collection and the autologous transplantation. And for many patients, including myeloma, it is very likely that it is currently better to plan autologous transplantation later on, and then to reorganize the treatment plan for those patients, for example, including additional cycles of therapy such as VRD or IRD, which has the advantage to be all oral drugs. Getting back,
I think this is, I can confirm that this is currently the recommendation of the IFM group, the French myeloma group, but this has been also endorsed by many other groups worldwide, that it is wise these days to postpone the auto transplant procedure for multiple myeloma and replace it with some additional cycles of induction. And we believe, and this is very important for our patient, there is no impact on survival, because we know very well from the randomized trials that the survival of those patients who proceeded to auto transplant versus those patients who did not proceed but received additional cycles of induction, as mentioned, whether VRD, VTD, VCD, is similar. So definitely here, it's a very wise and important recommendation that we need to put in place.
Absolutely, absolutely. The situation is a bit more complex for lymphoma, since some of the lymphoma subgroups definitely benefit of consolidation with high-dose chemotherapy supported with autologous transplantation. I'm referring to diffuse B-cell large cell lymphoma. Whenever they are chemosensitive, benefits from receiving high-dose chemotherapy. And in this situation, it may be necessary to not delay too much administration of high-dose chemotherapy. Again, this is a challenge to hospitals, but this is feasible. And it is important to stress that while we need to deal with these pandemics, we still need to properly care for our patients and again, re-examine the risk-benefit ratio in each situation. So at the moment, there is no shortage, to my knowledge, of disposables needed for apheresis, for example, so patients can undergo apheresis if this is deemed absolutely necessary. For other types of lymphomas, the situation may be a bit different. First-line high-grade lymphoma must be really discussed on a case-by-case basis, similar to for mantle cell lymphoma or for indolent lymphoma, where closer to the myeloma situation, it may be better to increase the number of cycles of chemotherapy before proceeding to autologous transplantation.
So Christian, because you are mentioning lymphoma, we also know that non-Hodgkin lymphomas, the CD19 positive lymphomas, are very important candidates in the refractory setting to CAR T cells therapy. So what is your attitude today regarding planning and administration of CAR T cells? Because we also know that this is an unmet medical need. And if these patients with refractory lymphoma, and it's true also for actually acute lymphoblastic leukemia, which is the other indication for CAR T cells, the commercially available CAR T cells, I would say, if the patient cannot get their CAR T cell, it will have a negative impact on their outcome. So what is your attitude? What is your recommendation in terms of CAR T cell planning and performance?
Well, again, this is a very complex issue and situation. To make it short, it's still possible to treat patients with CAR T cells when they need it. And I'm meaning the approved CAR T cells. So the two pharma companies that manufacture the two approved drugs, Agenlecleucel and Axicel, so far are able to maintain the supply chain, although their production facilities are located in the USA. So that's one aspect that you can still get the primary cells shipped to the manufacturing facility and get the product back to your hospital. But there are many other aspects to consider in CAR T cell treatments. We know that these new medicinal products can trigger some severe toxicities, including cytokine release syndromes, CRS, and neurotoxicity, ICANS. And a fraction of treated patients will need to be transferred to the ICU. So before deciding on whether or not to treat the patients, it is extremely important that the hematology department coordinates with the ICU to know whether or not access to the ICU will be possible in the near future, and especially during the 2 or possibly 3 weeks following CAR T cell administrations when the risk is higher.
Yeah, I think we are all in agreement with the fact, and this is very important issue. This is a very important issue you are raising, is that the practice of hematology generates a lot of admissions into intensive care. And during this crisis, we do have in many places, unfortunately, a shortage of intensive care beds. So we have absolutely to keep in mind that everything we do, everything we decide has to take into account the probability of sending this patient into the intensive care, and to make sure that an intensive care bed is available. And we should not forget that although obviously we are defending the interest of our patient and we would like to avoid any harm for them, we also have the duty to contribute to the collective effort of the hospital, of the city, of the national level, at the international level, to smooth, I would say, things in the hospital and help the overall planning. And that brings me, Christian, to the question about some specific allogenic stem cell procedures, like, you know, the borderline procedures in indolent myelodysplasia, chronic situations like MPNs, or even doing a second allo for relapse. What do you think the attitude we should adopt? Because we know very well these are patients, they are elderly, they have comorbidities, and they are at higher risk of getting severe complications and being admitted into intensive care. So what kind of guidance? I know it needs to be adjusted to a specific patient in a specific place, in specific circumstances, but what are your overall observations, I would say, or recommendations?
For all the reasons that you mentioned, and additionally for the even greater complexity of the supply chain, especially if we think of unrelated donors. At the moment, it becomes extremely difficult to get a graft from an unrelated donor, especially if the donor is living in a different countries than yours, especially in a non-European countries. For those of us who are based in Europe, it's really becoming an incredible challenge to get those products. And I am aware of several cases where actually the graft never reached the transplant center. So this is really a risky decision at the moment to try to obtain a graft from an unrelated donor. But more generally, for the reasons that we alluded to previously, every candidate patient should be carefully evaluated, both because the patient will be at risk to need access to intensive care unit. And as you said, we don't want to unnecessarily increase the burden on our colleagues working in ICU who already face a huge challenge managing the COVID-19 epidemics. So obviously there are some cases where the allo transplant may be delayed with no or very little consequence for the patient. I'm thinking of some non-hematological malignancies, but today we are focusing on hematological malignancies, so second transplant. Some myeloproliferative disorders may be treated for a few additional weeks or months with non-curative therapeutics, but waiting for a better time to receive their allogeneic transplant. Refractory disease should probably be delayed and converted to non-transplant modalities. And although it's very difficult to provide clear-cut guidelines, one line of thinking is whether we are using transplant as a consolidation therapy or rather as a curative therapy. Again, every center, depending on local organization, local circumstances, may have to make its own guidelines and adapt those guidelines as the pandemics develop.
Now, I think these are fair and wise recommendations when it comes to transplant, but I think we can also all do our part in this global fight, and at the local level, for example, and I can give you what we have done in my department here in Paris since 3 weeks. We really need to avoid the circulation of people and of course the virus, and this is about confinement. So avoiding bringing patients into the hospital is really a crucial issue. This is why whenever possible we're switching to oral drugs. We may say, oh, we don't have randomized trial, we don't have evidence-based, but these are, you know, extraordinary measures, extraordinary circumstances, and you need extraordinary measures. So switching to oral, switching to doing things at home, but of course it depends on whether you have available nurses and GPs going to the patient home. You know, hypomethylating agent can be administered at home. Lots of drug can be administered at home. We also tried to switch into once weekly administration of many drugs compared to twice weekly. Again, we need to be flexible, some dose adjustment. Even when they come into the hospital, you may wish to switch from IV to subcute to minimize the duration of stay in the hospital. Some measures avoiding contact in the hospital, so creating very specific circulation pathways and trying to identify those patients with fever and symptoms before they get into the ward or into your day hospital, and sending them into a specific path to make sure that there is no risk of contamination for the other patients who are in the ward or in the beds or wherever in the hospital. And this is why, for instance, 95% of our outpatient clinic consultations are moved into telemedicine, WebEx, Skype, video conferencing, with WhatsApp. I think everybody has WhatsApp, and you can have a very nice contact with a patient, high quality, and except in emergencies, in few cases, actually, we don't bring a patient to the hospital. Then that will decrease the workload on your healthcare, and your healthcare professionals are going to be ready if some of them get sick, unfortunately, or if they want to help other places in the hospital. And this is also true for the physicians, because as hematologists, we are called to participate to the shifts, to the consultation of other clinics to try to overcome the load of patients coming. So what did you apply, Christian? I mentioned the day hospital, the ambulatory care, but how are you handling the multidisciplinary meeting, the clinical research, the transfusion issues? Because we know very well that during confinement, donors may become rare.
Absolutely. So if there are but few positive aspects in this crisis, one is the acceleration in the adoption of telemedicine solutions. And all of us had heard for years that we should use more these solutions, but not much was happening. And the COVID-19 crisis really speeds up now adoption, as we are actually doing at the moment. Just we don't stay in the same room, but we still communicate very nicely together. So I think this is to stay. I don't think we will go back to the old organization once the crisis is resolved. And this is probably something that will improve our operations, not only now, but also in the future. You mentioned clinical research. Clinical research is a really difficult issue at the moment. It is consuming a lot of resource, including human resource, samples, people, data are traveling on long distances, and because of the disruption in the transportation system, it's very difficult at the moment to conduct clinical research. Many of the sponsors, whether academic sponsors or industry sponsors, have called to stop, a halt in patient inclusions. So in many trials, especially very complex and sophisticated trials, it is no longer possible to include new patients. For patients who are already included, this is a discussion on a case-by-case basis. So in some occasions, it is still possible to partly or fully monitor included patients. In some others, it is not. What is important to stress for people who listen to us is that safety of the patient is guaranteed, since patients can always return to a standard of care which will be provided. But for the next few weeks or possibly next few months, conducting clinical trials will be difficult, with the exception of trials that will focus on the issue of COVID-19 that must be prioritized, of course, and we need to better understand what are the consequences of SARS-CoV-2 infection in our patients. As you mentioned earlier in this discussion, we have preliminary data from our Chinese colleagues, mostly describing the worse outcome of patients with solid tumors, but we have very little information on patients with hematological malignancies, and we sometimes get very specific questions. I've been treated with ibrutinib for 4 months. What is my relative risk to non-treated patients? We don't have the data at the moment to answer this kind of question. And last important point is the supply chain for blood products. It's very important to maintain the blood supply for patients with hematological malignancies. This is one of the patient categories that needs most to receive transfusion. And although the red blood cell transfusions may not be threatened because planned surgery has been postponed, there is an issue definitely with platelets, for example. So most governments, although they have locked down countries, have issued provisions to allow donors to go to blood banks. And it is again very important that we encourage all of our citizens to keep donating blood.
I think, yeah, absolutely. This is really a crucial message, because while we are fighting and facing this coronavirus pandemic, we all know that the incidence of acute leukemia or other malignant diseases will not decrease. And we keep on receiving these patients. And we would like to continue to treat them state of the art in a curative approach. And we need these transfusions. So this is really a call for the generosity of the public. There would be absolutely no obstacles to go and donate blood and platelets to help the healthcare professional, the hematologists, the cancer doctors, the intensive care doctors to continue treat patient state of the art. And this is really very important. I'd like also to highlight, when it comes to clinical research, as far as I know, while most trials are put on hold, however, phase 1 trials or trials bringing new molecules that can be helpful in a desperate situation of a patient continue to be operated. And again, the key message for the whole community is that we would like to avoid any loss of chance for our patient, because we know it's very hard for them. They have the hematologic malignancies. Most of them, those hospitalized, are actually confined, isolated. They are not allowed to see any visitor because we have stopped all visitors into the hospital. And then, of course, you need to be able to deliver to them the appropriate treatment. So I believe this is extremely important. So, Christian, what is your concluding message, I would say, to our colleagues?
Well, very briefly, I would add a word about elderly patients. Elderly patients are especially frail in view of caring for hematological malignancies, and additionally, they are especially frail when getting infected with SARS-CoV-2. So we need to pay special attention to the elderly patients that we care for, and probably design specific rules to care for them. That said, again, I would like to thank all of you who have been listening to us. I would like to thank you for all the efforts you put to maintain good quality care to our patients. I would like to encourage you again to stay safe, keep good care of yourself, good care of your families, for yourself, and because we all need you at the hospital and all the healthcare facilities. So we wish that we will have other opportunities to exchange with you.
Yeah, this is absolutely very important and very nice. We need to be calm. We need to be resilient because it will not last forever. We need to minimize the losses. And I think the hematological community and the medical community worldwide is absolutely united against this new pandemic. But we should not forget all those guys, you know, who are allowing us to continue to treat our patient and to run the clinic without any loss of chance. I'm thinking about, you know, the ambulance drivers, the electricians who are keeping an eye on the power supply, you know, those guys in the supermarket, you know, allowing the supply chain and so on. So again, thank you all for your attention. We are all available. Please do not hesitate to write a message, to send an SMS, to send a tweet. I think there is a global coalition among hematologists and stem cell transplanters to allow all of us to go through crisis with little harm and avoiding any negative impact on our patient. So I think the community is devoted. We are all dedicated, and please stay safe. Thank you very much.
Take care. Bye-bye.